Pharyngeal pouch. A pharyngoesophageal pouch, also known as Zenker's diverticulum, is an outpouching of mucosa through the posterior pharyngeal wall, typically at Killian's dehiscence, an area of weakness between the inferior constrictor and cricopharyngeus muscles. It is considered a Pulsian diverticulum and is most often associated with impaired relaxation or discoordination of the cricopharyngeal muscle during swallowing. The pouch can accumulate food and secretions, leading to dysphagia and other complications. Peak incidence. It most commonly affects men over the age of 70. Pathophysiology. Zenker's diverticulum arises due to increased intrapharyngeal pressure against a functionally obstructed upper esophageal sphincter. This results in the herniation of mucosa and submucosa through the posterior hypopharyngeal wall. It is a false diverticulum, as it does not involve all layers of the esophageal wall. Symptoms: dysphagia, especially for solids but may progress to liquids. Regurgitation, often of undigested food hours after eating. Halitosis, due to food retention in the pouch. Chronic cough. Neck swelling, which may be visible or palpable, especially after eating. Aspiration pneumonia, from food or fluid entering the airway. Weight loss in advanced or long-standing cases. And retrosternal discomfort, often vague and non-specific. Signs: palpable neck mass, typically left-sided and fluctuant in large diverticula. Gurgling sound on swallowing, Boyce's sign. And signs of aspiration or malnutrition, such as cachexia or recurrent chest infections. Diagnosis: barium swallow with video fluoroscopy. This is the first-line investigation. This shows a contrast-filled pouch arising from the posterior hypopharynx. Endoscopy, used selectively. This helps evaluate for coexisting conditions, for example cancer and strictures. It must be performed with caution to avoid perforation. Esophageal manometry. This may be used to assess underlying motility disorders or to distinguish from mid or distal esophageal diverticula. Complications: aspiration pneumonia, due to regurgitated contents entering the lungs. Malnutrition, from chronic dysphagia and inadequate intake. Esophageal perforation, rare but may occur during endoscopy or spontaneously. Increased risk of squamous cell carcinoma. Although rare, long-standing diverticula are associated with malignancy risk. Management: endoscopic management. This is first line for most patients. Cricopharyngeal myotomy. This is division of the cricopharyngeal muscle to relieve the functional obstruction. Endoscopic diverticulotomy. This is division of the common wall, septum, between the diverticulum and esophagus using a stapler or laser. Suitable for small to medium-sized diverticula, 2 to 5 centimeters. It is minimally invasive with faster recovery and lower complication rates. Open surgical management for larger or complicated cases. Diverticulectomy. This is surgical removal of the pouch. Diverticulopexy. This is suspension of the diverticulum to prevent food trapping. These are often combined with cricopharyngeal myotomy to reduce recurrence risk. It is typically reserved for large diverticula, failed endoscopic treatment, and complications like perforation or suspicion of malignancy.
That was the full video, and there's hundreds more like it waiting for you at finalmed.co.uk. Get over 9,000 UKMLA exam questions, hundreds of animated videos, and our trusted textbook all in one platform designed to make your revision faster, clearer, and exam focused. Start your free 7-day trial today